However, we were unable to determine any different correlation between pain and tobacco status. So, in future, if using a larger population sample size, maybe the results might differ, and maybe we will be able to answer whether the tobacco use is causing the pain, or if the pain is causing the usage of tobacco status. Are there any other questions? Okay, thank you.
Dr. Hassan, first of all, great presentation. I really enjoyed how it was presented. I just wanted to ask if you had any explanation as to why an increase in age was associated with less pain there. Because when I reported, I said there's an increased reporting of pain in the elderly, right? So is there an explanation that you have any clue as to why? Or do you think it's underreported that they are older so they don't complain about it as much because they don't have diseases? Any idea?
Based on our literature review, it was found that older adults tended to have a higher pain threshold, and that is mainly multiple researchers have actually explored this, that they may be having higher pain thresholds. Any other questions?
From School of Medicine. During the discussion, we talked about the pain threshold. I noticed you have talked about number of people with chronic pain are females, with large proportion is females. Okay? So generally, I think females have higher threshold for pain, right? So what is the reason for this? So here we see like less number of males having pain. Is it because they are taking treatment for the pain they had before, or yeah, so what could be the reason for that?
Some studies have actually identified that there could be some central mechanisms involving this higher pain threshold in females.
Yeah, but here, in your case, you are saying females, large number of females are present with chronic pain, right? Less males. So what could be the reason?
Maybe that is based on the sample size that we have. So it could be because of the limited amount of participants that we have collected. Because our research data collection was from January up until March of 2026. So it's a quite a short duration of time. Right? So that could also have been a reason why the results came like that.
Another question is, you said chronic pain is more common in the age group 18 to 40, and again there was a gap 61 to 80. So what do you think is the reason for that?
So during our literature review, we found that there are some neurophysiological factors which affect the pain intensity and impact during the age in getting that advance. However, it was not still started in an research process was 2020. Thank you. That's all the time we have allocated for questions to this group. Let us now move on to our next presentation. The next study is titled Maternal Factors Associated with Preterm Birth with a Case Control Study at Indira Gandhi Memorial Hospital. Presented by Aminat Khatun, Safia Ali, Aminat Mihaya, Fatima Maisen Saeed, and Rafa Abdullah Samir, under the supervision of Dr. Ahmed Faisal, Dr. Huria Khairi. The stage is now yours. Assalamu alaikum. We are group 2 and we will be presenting about maternal factors associated with preterm birth. Preterm is defined as birth occurring before completion of 37 weeks of gestation. According to WHO, approximately 15 million preterm births are reported annually, with nearly 90% of preterm born seen in developing countries. In Maldives, prematurity accounted for 39.4% of newborn deaths in 2020 alone, and regardless of the growing incidence, there is lack of published data here, highlighting the need for further research. The objective of our study is to describe the characteristics of mothers of preterm newborns and term newborns born in IGMS, and to analyze the associations between antepartum factors, maternal comorbidities, the body parameters, namely hemoglobin levels with preterm birth in mothers of newborns born in IGMS from 2023 to 2025. Looking into existing published literature, globally, Africa and Asia have the highest preterm birth rate, with 49% in South Asia and 40% in Sub-Saharan Africa. Multiple studies have identified several maternal factors linked to preterm delivery, such as maternal age, underlying comorbidities, and pregnancy-related complications. This case control study was conducted at IGMH using medical records from 2023 to 2025, comparing women with preterm and term deliveries. Controls were matched by delivery month, year, and newborn sex. A final sample consisting of 830 participants was obtained, with 415 in each group. Preterm birth was defined as delivery at less than 37 weeks and term as delivery at 37 to 41 weeks. Only Maldivian women with live singleton births and complete records were included, while multiple pregnancies and congenital anomalies were excluded. Data was obtained from IGMH Delivery Register and Hindai system and analyzed using SPSS version 30. Descriptive statistics followed by chi-square tests and binary logistic regression was performed. Moving on to ethical considerations, this study was conducted with approval from MNU Ethics Committee, NHA, and NHRC. As it uses secondary data, there is no direct participant involvement and minimal risk. Data collection was limited to necessary information from hospital records. All data was stored in password-protected Excel sheets with personal identifiers replaced by a unique identification code to ensure confidentiality and anonymity. Final dataset will be deleted 6 months after research publication. Moving to our results and inferential study format, 15 newborns per group with a typical 56% male preponderance consistent with stated birth ratios described by Verma. 83% of our preterm cases were moderate to late preterm born between 32 and 36 weeks. For maternal age, the distribution was broadly similar across both groups, with the majority of mothers falling to the 20 to 34 non-advanced age range, representing 71.7% of preterm and 66.5% of term births. with a p-value of 0.426, age was not significant. In contrast to study by Hughes et al., which revealed that advanced maternal age was associated with preterm birth, with maternal age 30 to 34 years with the lowest risk. The parity profile showed that nearly 40% of the preterm group were nulliparous, while the term group had a slightly higher proportion of preterm mothers. 30% of the preterm group had a history of abortion compared to 25.8% in term cases. There was no significant association found, in contrast to Sun et al., who reported that pregnant women with a history of abortion were more likely to have preterm delivery. Urinary tract infections were present in 12.5% of the preterm group and 10.4% of the term group. The p-value confirms that there was no significant link between UTIs and preterm birth. Candidiasis rates were nearly identical across both term and preterm groups, affecting 28.4% of preterm and 29.6% of term mothers. There was no significant association between UTIs and preterm birth. Group B streptococcus infection was infrequent, occurring in less than 2% of the cases. It also remained statistically non-significant with a p-value of 0.129. Hypertension was present in 4.3% of preterm cases versus 2.4% of term cases. And at a p-value of 0.124, hypertension also showed no significant association, contrasting with the findings by Delta et al. And Farrakhan et al., who reported that a high risk of preterm birth is associated with maternal hypertension. Moving on to thyroid disorders, maternal thyroid disorders were more common in preterm birth, 7.2% versus 4.6%. This difference was not statistically significant. In contrast to the study by Wamza et al. 2024, which reported an increased risk of preterm birth associated with maternal thyroid dysfunction. Substance use disorder was observed only in the preterm group, 1.7%, and was significant on urinary analysis. However, this association was not retained after multivariable adjustment. In contrast, Baird et al. 2016 reported 1.5 to 2-fold increased risk of preterm birth. Gestational diabetes mellitus was 5.1% higher in preterm birth, but this did not reach statistical significance. Gestational hypertension was slightly higher in the preterm group, 0.7%, but this was not statistically significant. Anemia showed only a small difference with 1.2% more cases in the preterm group, and this was not statistically significant. This differs from a study conducted in Pakistan, which found a significant association with preterm birth. Normal hemoglobin levels were lower, while mild to moderate anemia was more frequent in the preterm group, with only one case of severe anemia observed. However, this difference was not statistically significant, contrasting with Young et al. 2023, who reported an association between low maternal hemoglobin at any time in pregnancy and preterm birth. Compared to term birth, oligohydramnios was 6.3% higher, polyhydramnios 2.2% higher in preterm birth. Overall, abnormal AFI showed a significant association with preterm birth. On logistic regression, oligohydramnios remained significantly associated with approximately 3-fold higher odds of preterm birth, whereas polyhydramnios was not significant after adjustment. Our findings is consistent with the study done in Pakistan, which reported an increased risk of preterm birth among women with oligohydramnios. Diabetes mellitus was higher in preterm birth, 12.8% compared to term birth, 2.9%, and was significantly associated with preterm birth. On adjusted analysis, mothers with diabetes had approximately 5-fold higher odds of preterm delivery. This is in line with the study done in China, which reported that pre-gestational diabetes was associated with preterm delivery as part of composite adverse neonatal outcomes. Preeclampsia was 9.6% more prevalent in preterm birth and showed a strong association. On logistic regression, it remained significantly associated with approximately 4.5-fold higher odds of preterm birth. This is consistent with the study done in Pakistan, which reported a significant association between preeclampsia and preterm delivery. Lastly, placental diseases were 5.6% higher in preterm birth and showed a significant association. In the existing model, placental diseases were associated with nearby 6-fold higher odds of preterm delivery. This supports findings by a study done in India, which reported an increased risk of preterm birth among women with placental previa. So for the strengths of the study, this is the first study conducted on maternal risk factors associated with preterm birth in the models. For the limitations, the study does not represent the whole population of models and there is a risk of incomplete documentation and inconsistent reporting of the variables. There are also several unmeasured variables that could influence preterm birth which were beyond the scope of our study. To summarize, there is a statistically significant association between diabetes mellitus, preeclampsia, oligohydramnios, and placental disorders as drivers of preterm birth. Those were also found to be at higher risk in females. We recommend targeted characteristic screening and healthier lifestyle choices. Further research should focus on conducting multi-center studies across different regions of the models for better generalization of our findings and also incorporate additional factors such as BMI, socioeconomic status, and lifestyle factors for more comprehensive understanding of preterm birth. Thank you. That was a very thought-provoking study, well into the field. For the next 5 minutes, the floor is open for questions.
You mentioned about several factors that you were not able to measure. And it's also the scale of BMI. Why was it?
We collected data mainly from the register of IGMH and from in Hanoi, it's not possible to get the social economic status. And also, BMI also was not recorded consistently. That's why we were not able to. Any other questions?
Studies should not be based on data collected from incomplete data sources. So maybe in the future studies can actually focus more on more productive and more enhancing mechanisms to similar studies. That might be a huge limitation to this study because BMI generally contributes to dementia, contributes to diabetes, so all these things. So rectifiable things we don't really expect to be unique indicators looking at patient. Anyway,
Can you explain that sentence?
So in our study, the number of male newborns were more prominent compared to female counterparts. There were more number of male newborns in preterm group.
Preterm, like more males are born preterm, right?
Yes.
That's what I remember. Okay, so next slide.
Okay, thank you. Thank you. Any other questions? Thank you. The next study is factors determining the decisions for cesarean sections and vaginal deliveries in Indira Gandhi Memorial Hospital from November 2025 to March 2026. Supervised by Dr. Asil Jalil, Dr. Shaista Zubair, and presented by Jaishun Abdul Majid, Mariam Arin Isa, Ashif Yasha Salim, Hassan Sham, and Muhammad Ayash Ali. Apologies for the delay. Assalamu alaikum, we are group 3 and the topic of our research is hospital-based study on factors determining the decision for cesarean sections and vaginal deliveries in IGMH from November 2025 to March 2026. These are the contents we will be looking at in our presentation. Vaginal delivery is the birth of the fetus through the vagina, also known as the birth canal, and cesarean section is defined as a surgical procedure where there is an incision made in the mother's abdomen and the uterus to deliver the fetus. A study done in Maldives in 2012 which analyzed the data from IGMH and ADK showed that C-section rates were significantly increasing in the country. According to the latest statistics available in 2021, C-sections accounted for 53% of all births in the Maldives. Although there is evidence that C-section rates are increasing in the country, there remains a lack of clarity about what drives the decision-making process behind these procedures.
The purpose of this study is to analyze the factors determining the reason for C-sections and vaginal deliveries among women represented person when employment of IGMH by exploring the maternal and fetal characteristics. The objective of this research is to examine and analyze the various maternal and fetal factors associated with C-sections and vaginal deliveries expected to be carried out with IGMH during study duration. These are research questions. We looked into the distribution of women undergoing C-sections and vaginal deliveries at IGMH and various maternal and fetal factors associated with both modes of delivery. This is our analysis.
Looking into the methodology of the study, this was a hospital-based cross-sectional study conducted at IGMH. We used a quantitative descriptive approach to assess factors influencing the mode of delivery. Our study population included all women who delivered at IGMH during the study period using census sampling, and this resulted in a total sample size of 394 participants. We used an online questionnaire and interviewed the patients to collect the data. A pilot study was conducted for 1 week involving 26 participants. This helped assess validity and reliability, and necessary modifications were made before the final data collection. Participants of the study included women aged 18 and above who underwent either cesarean section or vaginal delivery, and only those who provided informed consent were included in the study. We excluded minors those who declined the participation, and women with severe psychiatric conditions were also excluded. Data was recorded on Google Sheets using tablets, phones, and laptops, and access was given to only the research team members, the supervisors, and the system module coordinator. And the data analysis was performed using Excel and SPSS, and descriptive statistics were used to summarize the data. And non-parametric tests such as chi-square, t-test, and man-beating units were also used.
Now move on to the literature review. According to the statistics from WHO, the rate of C-section deliveries has dramatically increased from 7% in 1990 to 21% in 2021, which is more than 1 in 5 childbirths. And according to WHO, this number is projected to reach 29% in 2030 globally. The trends of C-sections were analyzed in 154 countries worldwide from 2010 to 2018, which showed the C-section rates were 21%. And a study done in 2020 with 9 countries of South and Southeast Asia showed that the C-section rate in our part is highest among women in Maldives. which accounts for up to 39.07%, which is followed by India, Bangladesh, Vietnam, Pakistan, and Indonesia. And according to the ANC guideline of Moody's, common maternal indications for C-section include obesity with comorbidities like diabetes, preeclampsia and eclampsia, and fetal indications which include abnormal presentation, fetal distress, placenta previa, and multiple pregnancy.
Looking into the ethical issues of our study, all ethical guidelines were strictly followed and informed consent was obtained from every participant ensuring voluntary participation within and with the right to withdraw at any time during the questioning. And participant confidentiality was maintained by
Conducted to compare maternal age between C-sections and vaginal deliveries, the mean maternal age was higher in the C-section group compared to the vaginal delivery group. This difference was statistically significant with a p-value of 0.025. This suggests that maternal age is significantly associated with the mode of delivery, with mothers undergoing C-sections being slightly older. A similar study done in India showed that the age was significantly associated with preference for mode of delivery, and this is consistent with the results of our study as well.
Looking into some other social demographic factors, a majority of the study population was married, accounted for 96.7%, and 44.2% had received secondary education, while 34.5% had college degrees. And looking into occupational status, 49.8% of the participants of the study were employed, while 50.3% were outside.
Out of 394 participants of the study, 44.1% had undergone vaginal delivery, 37.7% had undergone emergency C-sections, while 18.2% had undergone elective C-sections. Looking at some of the maternal factors, 26.1% of the women had pre-existing comorbidities. Among them, the most common were thyroid disorders, diabetes mellitus type 2, and hypertension. A chi-square test was done to study the association between these maternal factors and the mode of delivery. It showed that there is no significant association between the two variables. This contrasts with a similar study which states that individuals admitted with C-sections had more pre-existing comorbidities than those whose intended mode of delivery was vaginal. This disparity could be due to the comparatively smaller sample size of our study, and therefore this could be an area of interest for further research to be done. BMI of all the participants before and after the pregnancy was calculated, and they were categorized according to the Asian guidelines. Results showed that a majority of the women were either overweight or obese. We then referred to the American College of Obstetrics and Gynecology guidelines for appropriate weight gain during pregnancy and compared the weight gain of the participants of the study. We found that 65.7% of the participants did not meet the core criteria. The chi-square test demonstrated a statistically significant association between BMI and the mode of delivery, indicating that individuals with higher BMI are significantly associated with a higher likelihood of C-sections compared to individuals with lower BMI. This aligns with the case control study done in China, which stated similar results. Moving on to obstetric factors, 28.7% of the participants were noted to have obstetric conditions during their pregnancy, among which the most common were gestational diabetes mellitus and preeclampsia. A chi-square test was performed, which revealed there is no significant association between obstetric conditions and mode of delivery. However, other studies contradict this. Moving on to the next factor, which is method of conception. 93.7% of the women conceived naturally, while 6.3% had used assisted reproductive technology such as IVF and IUI. A chi-square test was performed and it showed a significant association between method of conception and mode of delivery. However, there is limited research available on this aspect, and it could be an area of interest for further research to be carried out since this is becoming more accessible worldwide. Our findings showed that 26.4% of the women had history of previous C-sections, while 73.6% of the patients had no previous history of C-sections. Among the total cases with history of previous C-sections, 51% had undergone elective C-sections, while 40.4% of them had undergone emergency C-sections. The rest had undergone vaginal deliveries. Chi-square analysis showed a p-value less than 0.05, indicating a statistically significant association between history of previous C-sections and mode of delivery.
Looking at the men with new test which was performed for gravidity, it showed that women who had vaginal delivery generally had a higher gravidity compared to those who had cesarean sections, indicating a statistically significant difference in gravidity and the modes of delivery. And the results align with the observations in recent studies
study done in a tertiary hospital in India in 2024, which showed that 36.4% of the participants were primary resident. And analysis was also done for parity, which showed that there is no real difference in the parity between women who had C-sections and vaginal deliveries with a p-value of greater than 0.05. And looking at the fetal factors, the gender distribution in the births given 15.3% accounted for males and 49.7% accounted for females. And in this population, 97.7% does not have any fetal anomalies. The majority of the babies had a birth weight in a normal range and accounted for up to 83.2%, and a minority of them had extremely low birth weights. And a chi-square test was performed showing a p-value of greater than 0.05. This showed that there is no significant association between the birth weight of the neonates and the mode of delivery. And a study done in Manipur, India in 2019 showed the results which aligned with our findings. Looking at the fetal presentation, 92.4% had a cephalic presentation, and the chi-square showed a p-value less than 0.05%, showing that non-cephalic fetal presentations are significantly associated with an increased likelihood of C-sections compared to vaginal deliveries, and this also aligns with our studies.
Moving to the strengths of our study, this is the first known study done in Hall to determine the factors affecting vaginal deliveries and cesarean sections, which was carried out in IGMH. Thus, it is anticipated to offer valuable insights for consultants and clinicians, aiding in decision-making and policy-level changes, enabling better patient care and outcomes. Moving to limitations, this study excludes other influencing factors such as healthcare provider preferences and institutional policies and factors which are beyond the scope of this study. In this study, our main limitation was the smaller than estimated sample size. The sample size was initially calculated to account for a study duration of 6 months. However, due to formalities, the duration of the study was cut back to 3.5 months. However, despite this setback, we were able to get a majority of the estimated sample size within the sample collection duration. In conclusion, our study highlights the distribution of the mode of delivery among the patients who gave birth in IGMH and their determinants. The study demonstrated that several factors had a statistically significant association with the mode of delivery, which includes maternal age, gravidity, history of previous C-section, method of conception, BMI, and fetal presentation. Our recommendations in this study is to expand participant recruitment across multiple healthcare facilities to increase sample size and expand the duration of the study. Finally, a special thanks to everyone who helped during our research. Thank you.
We truly appreciate the effort and depth of research demonstrated. Well done, team. Once again, we will now open the floor for questions for the next 5 minutes.
Hello. You mentioned in the exclusion criteria that you have excluded severe psychiatric conditions. I would like to know what these severe psychiatric conditions are and why you have excluded.
So for our study, we did interviews, technical interviews. So we excluded patients with severe psychiatric conditions like schizophrenia because it would be difficult to interview the patients and get the required data from them, and that's why we excluded.
Any diagnosis of schizophrenia or people who are psychotic?
Thank you.
Any other questions? With that, let us move on to study.
If there are no questions, I can ask some questions from you. From School of Medicine. title says factors determining the decision for cesarean section. Maybe I missed something that you presented, so I would like to ask you to summarize what are the factors determining the decision for cesarean section among the subjects you studied.
So we studied various maternal, obstetric and fetal factors, and from our presentation, the statistically significant associations with mode of delivery was noticed from maternal age, validity, history of previous cesarean sections, method of conception, BMI and fetal presentation. So these are the ones that we found associations.
So these are the things we found as associated factors, right? So the decision-making factor, is it based on the age which will be settling the decision was made? That's what I want to know. Maybe I am misunderstanding, but from the title I feel like there should be some finding like that. Maybe the one person might have multiple factors, associated factors, right? But all the factors may not be the deciding factor for the decision of cesarean section, isn't it? So that's what I want to know.
I think that study can actually be extended to account for more samples, and then we can come to a decision on what actually contributes to some of the factors. I think that's one of the implications of our study, which can be influenced. But I think that even from our study, with such a little sample size, we were able to find that there are associations. I think that is something that is important.
So in the future, maybe we can do another research, right? On what exactly find what are the decision making factor. Okay, thank you.
Oh, is anyone I just wanted to clarify, right? First of all, great presentation, like lots of presentation, I really appreciate the design and so on. I wanted to color coordinate also, really good one. So, what I wanted to ask, can you go to the inclusion criteria? The inclusion criteria. You have included reference from other healthcare facilities. Can you tell me why that is?
So IGMH is one of the IGMH is where our study is conducted. So and since IGMH is one of the main referral centers in the country, in the region, that's why we have to include it.
So my question is, wouldn't that create an inherent bias? Because any patient that can refer from an upper hospital generally are complicated cases that usually predisposed for cesarean sections. Right? So again, wouldn't that skew your very fact towards patients who have more complicated cases? So that's why I just feel that like why you do that. Apart from that, it's sensitive.
Thank you. With that, let us move on to our next presentation. Iron deficiency anemia and correlation with vitamin D deficiency in pediatric population attended IGMS from January 2023 to December 2025. Supervised by Dr. Aishat Elena, Dr. Milza Abdul Muhsin, and presented by Aishat Maisha, Malaha Hussain Shawa, Luman Ahmad Reza, Shabab Hassan and Maria Beshka. The next presentation is Effect of Awareness Level on Breast Cancer Screening Behavior and Barriers among working women, a cross-sectional study conducted in Greater Mumbai area, supervised by Dr. M.D. Parvez Ahmad, Dr. Shaista Zubair, and presented by Aminat Rifasha, Fatma Dilma Muhammad, Fatma Yufa Fatahi, Aminat Inam Sameed, Aishat Madal Sameed. Assalamu alaikum. We are group 4 and our research is about the effective awareness level on breast cancer screening behavior in barriers among working women. These are our table of contents. Breast cancer is a broad and significant topic that can be studied from many different perspectives. It affects millions of factors, awareness level and breast cancer screening behavior, and to understand the barriers that impede women from practicing breast cancer screening. Our null hypothesis states that there is no significant association between awareness about breast cancer and screening behavior. Our alternative hypothesis states that there is a significant association between awareness about breast cancer and screening behavior. Looking into some previous literature, a systematic review conducted in East Africa in 2023 revealed a lack of awareness and knowledge about breast cancer and its screening methods significantly hindered screening uptake even among educated and employed women. Another study conducted in Morocco in 2024 revealed that majority of the participants were unaware of complex risk factors associated with breast cancer. A study conducted in Maldives by Niam et al. 2021 showed that the most dominant predictor of breast self-examination was having heard about it, with a twofold increase in the performance of breast self-examination than those who have not heard about it. Additionally, it showed that women who are more aware about breast cancer screening are more compliant with breast cancer screening behavior.
Outlining the methodology. Our research was a community-based cross-sectional study conducted in the Greater Mumbai area from February 2025 to April 2026. We used quota convenience sampling method. Our target population consisted of working women aged 80 to 65 years. As for inclusion and exclusion criteria, We included Maldivian women aged 80 to 65 who are currently working in an office or institutional setting within the Greater Amman area. We excluded individuals outside this age range and those residing beyond the Greater Amman area and of non-Maldivian nationality. In addition, those working from home to maintain a focused and consistent study population. Our calculated sample size was 381. However, we were able to obtain 308 samples. After exclusion, we had 305 responses. Looking into data collection, management and analysis, first approval was obtained from relevant organizations and authorities. Participants were then recruited using a quota convenience sampling method. Data was collected by the primary researchers using a structured Google form after obtaining informed consent. The collected data was entered into Google Sheets followed by validation and verification to ensure accuracy. Data analysis was performed using SPSS software where descriptive statistics were generated and chi-square test was applied to assess associations. Regarding our ethical considerations, approval were obtained from NHRC and MNU. Informed consent was taken after explaining the study and sensitive topics were handled with empathy and confidentiality. Moreover, we ensured that the data collection environment respected participants' comfort, dignity, and autonomy. We also maintained the confidentiality of all participants. We securely stored all collected data in a password-protected file. We upheld integrity and did not misuse the research project for any personal or professional purpose.
I will now proceed with the findings of our study. A majority of our study population were from the age group 30 to 39 years, which was 40.3%. This was followed by 18 to 29 year age group with 31.1%. 49.2% of the participants have achieved a degree or higher education, while 18.7% have completed their own work. A significant 68.9% of the participants indicated that their workplace did not conduct any screening programs. Among the participants, only 13.8% reported a positive family history of breast cancer. Notably, of those with a positive family history, 97.6% demonstrated good awareness of the disease. Within our study population, good awareness was observed among the majority of participants irrespective of education level. In contrast to a study by Al-Mashari et al. 2023, in which it determined the participants having an overall average knowledge, our study demonstrated a higher overall awareness of 87.5%. Next, we'll be focusing on the screening behavior. Across the study sample, 55.7% of participants performed BSc. However, it is concerning that most participants perform it annually rather than at the recommended monthly frequency. This is consistent with the study by Hassan et al. 2025, where 82.4% performed BSc, but 67.7% lacked knowledge of the correct technique. Among the study population, 69.2% of the participants did not perform clinical test examination. Among those who performed, the majority performed as recommended. However, these findings are in contrast to those reported by Niaf et al. 2021. Even though mammograms are performed by only 15.1% of the participants, 56.5% of them performed annually. A similar trend was seen in a study conducted in Turkey by Nuran et al. 2025. Across all education levels, there was no significant pattern in screening behavior observed among the participants. A marginal difference in screening behavior was observed as 52.8% of the participants had good screening behavior while 47.2% had bad screening behavior. Next up, we are looking at the barriers to screening. The commonest barrier to perform breast self-examination is that doing breast self-examination worries the participants about the breast cancer, with the 21.6% of participants agreeing to it. This aligns with the previous systemic review done in East Africa in 2023. Lack of female physician and queue being too long for a consultation was the most notable barrier which hindered the practice of clinical breast examination with percentage of 51.8 and 49.5 respectively. This result corresponds to results of Mahmood et al. 2020. The primary barrier to mammography identified was fear that routine screening may increase anxiety regarding breast cancer and the belief that the procedure is painful, reported by 26.2 and 25.2% of the participants respectively. So in overall, there are no significant barriers that prevent women from undergoing screening practices.
These results indicate that individuals who demonstrated good screening behavior also had a high level of awareness with 48.5%. We got a p-value of 0.004, which is less than 0.05, so we reject our null hypothesis. Therefore, there is a significant association between awareness level of breast cancer and screening behavior.
Similar to existing researches, our research also has its own strengths and limitations. One of our biggest strengths is that our questionnaire is adapted from validated standardized toolkits. This increases the reliability of our research as these toolkits are already pre-tested. Data collection via face-to-face interviews reduce the likelihood of participants using external sources while answering the questions, further improving the data accuracy. Moreover, the data was collected in a private setting to ensure the confidentiality and comfort of the participants. According to the Labour Force Survey 2025, the Maldivian population comprises of 51.6% of working women, and so far this is the first study conducted in Maldives targeted to this population. As for the limitations, one of our main constraints is that we had a response rate of 80% of the intended sample size. The research was focused on the female working population of Greater Male area Maldives. Therefore, this research may not be generalized to the whole working population of Maldives. A major limitation of this study is that some organizations initially provided approval but later declined participation or did not respond, which reduced our access to potential participants. Based on the outcomes of our research, it is evident that there is a need to increase female enrollment in surgical field, and moreover, efforts need to be put into engaging working women in breast cancer screening programs in a feasible manner at the workplace. This can be reinforced by carrying out awareness sessions followed by screening programs. I would like to conclude this presentation on the note that increased literacy towards breast cancer will result in higher screening rates, subsequently giving rise to improvements in preventive care. Thank you.
That was a very thought-provoking study. Well done in the field. Once again, we apologize for the research. The floor is now open for 5 minutes of questions.
Hello. I think I'm wrong, but correct me if I'm wrong. You mentioned that the data was taken face-to-face interview, but I remember seeing in the first few slides, you mentioned a Google form was used where the patients, participants fill the blanks.
Thank you for the question, Doctor. We used a questionnaire which was a Google form. So by doing a face-to-face interview, we filled those Google forms to obtain the data.
Any reason why unworking women were excluded?
Our target population for this study is working women in Greater Male area. That's why.
And Doctor, and also because a huge population of Maldives comprises of a working population, so that's why we decided to focus on the working women of Greater Male area. Any further questions?
Okay, thank you. With that, let us move on to our next presentation. Iron deficiency anemia and correlation with vitamin D deficiency in pediatric population attending IGMS from January 2023 to December 2025, supervised by Dr. Aishat Elena, Dr. Mirza Abdul Muhsin, and presented by Aishat Maisha, Malaka Hussain Salah, Juman Adam Nizam, Shahamat Hassan, and Maria Mirza.
Assalamualaikum. Good afternoon. We are group 5. Our research title is Iron Deficiency Anemia and Association with Vitamin D Deficiency in Pediatric Population attending ITMH from January 2023 to December 2025. These are our table of contents. Looking into an introduction. Iron is an essential micronutrient required for hemoglobin synthesis and other cellular processes. In fact, the majority of iron in the body is found in hemoglobin, which is the oxygen carrying molecule in our body. When iron stores are depleted, it reduces iron availability, resulting in iron deficiency anemia. Clinically, this manifests as fatigue, dyspnea, and impaired cognition in children. Next is vitamin D, which is a prohormone, which is mainly produced by sunlight exposure, where ultraviolet radiation, and it maintains calcium balance, bone growth, and immune function. Globally, iron deficiency anemia and vitamin D are recognized as public health concerns and is also highly prevalent in Maldives. However, there has been no study so far. Therefore, our objective of this study is to find the proportion of anemia, iron deficiency anemia, and vitamin D deficiency, and to determine the association between iron deficiency anemia and vitamin D deficiency among the pediatric population attending IGMH. Therefore, our null hypothesis of our research is that there is no significant association between iron deficiency anemia with vitamin D deficiency, and our alternative hypothesis is there is a significant association.
So looking into some literature, studies have identified a possible physiological influence of vitamin D and iron in each other. For example, decreased levels of iron may reduce availability of the active form of vitamin D. In addition, studies have shown that vitamin D can improve the levels of iron by inhibiting hepcidin, which is the main regulatory hormone of iron. The possible association between iron deficiency anemia and vitamin D deficiency has been studied worldwide. Vitamin D deficiency was identified as a risk factor among South Korean children aged 10 to 20 years for iron deficiency anemia. In addition, studies in Iraq and Turkey have shown that vitamin D deficiency was more prevalent in children with iron deficiency anemia. For vitamin D and iron, the risk factors are relatively common. Inadequate dietary intake of these micronutrients, which may be paired with increased demand during phases of rapid growth, as sedentary lifestyle with reduced outdoor activities, especially in growing children, have been identified as risk factors. Female gender is also another risk factor. Females have a higher prevalence for iron deficiency anemia due to extra blood loss during menstruation, and they have a high prevalence for vitamin D, which is attributed to the cultural clothing choices among females, so there is limited studies for that.
Looking into the methodology, in our study, deficiency was defined using a specific cutoff values of hemoglobin according to WHO criteria, along with serum creatinine less than 30 nanograms per milliliter. Vitamin D deficiency was defined as 0.5 hydroxy vitamin D levels less than 20 nanograms per milliliter. Moving on to the research design, our research is a hospital-based retrospective study. The research constituted study design, a cross-sectional study to find the proportion of anemia, iron deficiency anemia, and vitamin D deficiency, and a nested case control study including children with iron deficiency anemia as cases and children without iron deficiency anemia as controls. Find association between iron deficiency anemia and vitamin D deficiency. The cases and controls were chosen based on the following inclusion-exclusion criteria. We included children under 18 years of age who had laboratory investigations done in IGMH from 2023 to 2025 and had complete laboratory data. Children with underlying diseases or who were on iron or vitamin D supplements were excluded. For the research sample, data obtained from the medical records of IGMH show that a total of 2,046 children had done all three investigations of hemoglobin, serum ferritin, and vitamin D levels. Among them, 456 children with iron deficiency anemia were chosen as a case group, and the age and gender match. 456 children without iron deficiency anemia were chosen as a control. For this study, IGMH medical records were used to obtain data. Fanaaru was used to check participants' history to evaluate the participants for eligibility based on inclusion-exclusion criteria. The data was recorded and analyzed using SPSS software. Descriptive statistics was used to summarize based on characteristics, and chi-square test was used to find the association between iron deficiency anemia and vitamin D deficiency.
considerations, prior to data collection, medical approval was obtained from NHA, NHRC, and MNU. Patient competency was maintained by using a unique identification code and by collecting the data in password protected sheets. And as this was a retrospective study, patient interaction was kept in a minimum.
We'll look into the results and impressions. So in our study, population 58.8% on females and 41.2% on males. Mean age of participants was 8.4 years. The analysis of hemoglobin level shows that 28% of the study population were anemic. This is described as a moderate public health concern according to WHO. Anemia was also more prevalent among females with a prevalence of 60%. These findings are consistent with studies from Egypt and Ethiopia, which reported similar anemia prevalence of 21.1% and 38.7% respectively, with higher prevalence identified among females than males. The prevalence of anemia was found to be more common in the age group less than 5 years. These findings are consistent with studies among children under 5 years from Ethiopia, which was 41% and anemia prevalence, and in Brazil, 57% anemia prevalence was found among under 5 years. The analysis of iron levels shows that 53% of the children were iron deficient, out of which 64% were females. Overall, iron deficiency was relatively high across all age groups. A study in India shows higher prevalence of iron deficiency in females compared to males. Other studies report much lower overall prevalence of iron deficiency. For example, a study in Spain shows 7.7% and in Brazil it shows 14.2%. However, these differences may be due to variation in ferritin threshold used in the study. In our study, 24% of the children had iron deficiency anemia. 24% of children had iron deficiency anemia, with 59% of them being females, and it was most prevalent in the age group 15 to 18 years. These are similar to study done in Saudi Arabia, which shows 22.5% anemia prevalence, iron deficiency anemia prevalence, and in Ghana 30.4% prevalence was shown. However, in Indonesia it shows a much lower prevalence of 5.8%. And among all these studies, the prevalence of anemia was found with more in females compared to males.
So looking at the vitamin D analysis, we found that 51% of the children had vitamin D deficiency, out of which 69% were female. This is similar to a study conducted in Dubai in children under the age of 18, where 39.2% of children were identified to have vitamin D deficiency. A study in Tehran, Iran, where 86% of primary school children are also vitamin D deficient. In both these studies, the prevalence among females is higher. Seeing the trend for age, we see that there is an overall increase in vitamin D deficiency with increasing age. And this is consistent with the study in Romania, which suggests that the vitamin D deficiency prevalence increases with increasing age. So finally, the chi-square test results, in which we were assessing the association between the case and control group, we found that vitamin D deficiency was most prevalent among children who were diagnosed with iron deficiency anemia. We got a p-value of 0.002, therefore we can reject our null hypothesis. Therefore, our study suggests that there is a strong association between iron deficiency anemia and vitamin D deficiency among the pediatric population attending IGLH. This is consistent with studies conducted in Pakistan, India, and Bangladesh, where there was a prevalence of vitamin D deficiency of 67.5% and 4% and 46% respectively.
So now we'll be discussing about strengths and limitations. So strengths, since the study was conducted in IGLH, which is a tertiary referral center, the sample population can represent a multi-age population. In addition, the data of 3 years was collected and the children of most recent data was chosen, which includes clinical relevance and accuracy. And as for our limitations, our study depended on exhaustive medical report, in which there was no control over the quality of the data collection. In addition, the sample size was to become smaller because due to incomplete data or strict selection criteria. So in conclusion, our study suggests iron deficiency, anemia, and vitamin D deficiency are a significant public health concern among the moderate population, and highlighting the importance of routine screening for iron and vitamin D levels from an early age. In addition, this serves as a baseline for further research on the establishment of risk factors and early intervention of iron deficiency anemia and vitamin D deficiency. Thank you.
engaging. Thank you for sharing your work. Once again, for the next 5 minutes, the floor is open for questions.
The presentation and so the presenting for this study. I appreciate the humor of whoever put children over the age of 18 years as exclusion criteria. I am also a child at heart, I take it 31. So, but I wanted to actually ask you about the confounding factors that you accounted for. If you go ahead, testing given had discussed hereditary anemia and vitamin D, right? So, did you notice any difference between the men, the males and the females with regards to those right conditions? Was there any prediction for the men having more hereditary anemia, vitamin D deficiency or in the women? And if it was in the girls, right, in the age category of 12 and above, was there any confounding factor that you attested for? I am asking this because there are women who are not as examples of cultural practices and stuff like that. So I want to ask if you did account for those confounding factors.
The main thing which we focused on was keeping the both the case and control group concept with the age and gender. So when we did analysis also, it was as comparing the child with the same age and gender. So
That's a very important thing.
Any other questions?
I think I'm loud enough, so I won't be using the mic. So first and foremost, I'd like to congratulate on a very wonderful presentation. In the end, you mentioned that you recommend screening programs for iron deficiency, anemia, and vitamin D. So my question is, like, how often do you think the routine recommendation you should practice for the pediatric age groups?
more than being a routine screening thing, I think it would be appropriate that when children are at a young age, like to do a laboratory investigation maybe once a year to find out whether how they about the iron and vitamin D levels. Because if it is iron, the science may not show until it has depleted to a very significant level. So if once a year would be a good time period.
Okay, thank you.
I would like to ask, I noticed that you have compared most of your results with the studies from underprivileged countries, isn't it, like neighboring countries? So did you try and look for studies done in developed countries?
Even from the developed countries, we came up with studies, but there was not a significantly, there was not a significant difference in the prevalence, I would say, but there was not a significant difference. We came across some studies from USA and some European countries, but there was, in those countries also, it was considered a public health concern for the population.
Most of the literature you found it was the females are having these deficiencies more prevalent. So sometimes some cultural issues, there are tendency to have nutritional deficiencies among females, really. So that's why I wanted to know whether some type of exploration was there and study coming.
I came across a study which was comparing Southeast Asians who are living in the developed countries, comparing with natives, and it was found that the Southeast Asians were more prevalent to have the deficiencies compared to the Europeans, because their lifestyle is considerably different, and also they are more indoors, and then therefore those are the two factors which are identified in the.
Okay, thank you.
The next presentation is normal kidney size evaluation using ultrasound and computed tomography database in Moldovan adult population presented to a tertiary hospital from 2021 to 2025. Supervised by Dr. Ibrahim Shihab, Dr. Aminat Huda, and presented by Aminat Riha Naim, Aminat Dania Ali, Fatma Ufka Habib, Khadija Shiha, and Maryam Noura Ali. Bismillahirrahmanirrahim. Assalamu alaikum. Good afternoon, everyone. We are group 6 and we will be presenting normal kidney size evaluation using ultrasound and computed tomography database in Moldovan adult population presenting to a tertiary hospital from 2021 to 2025. To begin, this is an overview of our presentation. Kidney size is an important clinical parameter that reflects renal health and function. Accurate assessment of kidney size is essential in diagnosing and monitoring various renal conditions where commonly USG and CG is used. However, there is limited population-specific data available for the Moldovan population. Therefore, this study aims to evaluate normal kidney size using USG and CG data for our local setting. The objectives of our study are to estimate the average size of the normal kidney in Moldovan adults with no renal impairment based in Indira Gandhi Memorial Hospital data, to analyze variations in normal kidney size across different age groups in the Moldovan adult population, and to analyze variations in the normal kidney size between males and females in the Moldovan adult population. The first null hypothesis is that there is no correlation between age and kidney size in the Moldovan adult population. The alternative hypothesis suggests otherwise. The second null hypothesis is that there is no significant difference between male and female kidney size in the Moldovan adult population. The alternative hypothesis states otherwise.
Moving on to the literature review, kidney disease is associated with increased morbidity and mortality and is the fifth most common cause of death in Moldovan, contributing to 3% of deaths from FCDs, adding to the healthcare burden. Indeed, the Moldovan study on the global dialysis perspective by Abdullah and others notes that among dialysis patients presenting to ITMH, hypertension may be overdiagnosed as the underlying cause of kidney failure, when in fact the underlying etiology could be glomerulonephritis or diabetic nephropathy. And the study notes that this issue is highlighted by South African Renal Registry as well. Kidney size is a valuable parameter to assess for kidney disease. Various studies do show that renal dimensions are influenced by multiple factors, including gender, body habitus, and age. And notably, there are significant variations in kidney size across different ethnic groups. In evaluation of kidney size and other morphological features, ultrasonography is the preferred method in clinical settings due to the availability, lower costs, no radiation, and non-invasive nature. However, the consensus is that CT is more accurate as it utilizes 3D information. In most studies, measurements taken when assessing renal dimensions include pole-to-pole length, the width, and cortical thickness. But since the shape of the kidney is complex, the renal volume is more sensitive in determining kidney size. Included participants with known renal conditions, participants with a measurement discrepancy of more than or equal to 2 cm between CT and USG, pregnant participants at the time of imaging, and those with incomplete medical reports. These are the instruments and materials used in our data collection. Firstly, ethical approvals were obtained from the Moldovan National University, National Healthcare Academy, and National Health Research Council. Data was then collected from medical records and INAI. The variables collected included kidney length, eGFR, serum creatinine, and underlying conditions. This data was then entered into a Google sheet, cleaned, and then transferred into a separate sheet where it was cross-checked for input errors. Initially, a total of 2,554 records were obtained, and after cleaning the data and applying our criteria, 561 patients remained. From this, our final sample size was 383,000. The data was first cleaned and then coded and analyzed using Microsoft Excel and SPSS, with access restricted to password protection and limited only to the research team. Descriptive and inferential analysis were performed.
I'll be looking into the ethical considerations of our research. Relevant approvals from SM, NHA, MNU, and NHRC were taken in
before commencement of our research. No identifying data other than medical record number was collected and was replaced with a unique code to anonymize, and all data collected was restricted to only the research personnel. Moving on to our results and discussions, a total of 383 participants were included in this study. The demographic distribution showed that 59.3% were females and 40.7% were males. The majority of participants were in the 50 to 59 age group with a mean age of 47. Regarding the clinical parameters, the mean serum creatinine levels among participants was 0.93 in males and 0.71 in females, and mean glomerular filtration rate was 94.5 milliliter per minute per 1.73 meter square. In terms of comorbidities, 90 participants had no known renal medical illness. Among those with comorbid conditions, most common was hypertension, seen in 100 participants, followed by diabetes mellitus, seen in 86 participants. Additionally, 277 participants had other comorbidities like dyslipidemia, COPD, bronchial asthma, and cardiac conditions. Kidney size was assessed using both USD and CT. On USD, the mean size of the right and left kidney was 10.04 and 10.26 respectively. On CT, the values were 9.99 centimeters for the right and 10.3 centimeters for the left. Overall, the left kidney was slightly larger than the right, which is consistent with the findings from India, Pakistan, Bangladesh, and Sri Lanka.
Now let's look into our differential statistics. So when comparing age groups with right kidney on both CT and USC, there was a significant correlation between age and right kidney length with a p-value of less than 0.05. When this comparison was done with the left kidney on both CT and USC, there is a significant correlation between age and left kidney length with a p-value of less than 0.05 as well, and therefore we rejected the null hypothesis. Which means according to age group, there is a significant change between the dimensions. So these findings are consistent with the findings of Firas et al., Nazma et al. However, Al-Rashid and Abdul Fattah shows that there is no significant correlation between age and kidney size in patients over the age of 60. When comparing kidney size and gender on USD, there is no significant correlation between mean renal length in males and females. However, on CT, it was noted that males had a larger right renal length than females with a p-value of 0.025. There was no significant difference noted in the left, therefore we accepted the null hypothesis. This is supported from other studies like Saha et al., which show that males have larger kidney dimensions compared to females, and studies done in Iran and North India, including Tawa et al., Singh et al., and Falafel et al., shows that there is a significant difference between right kidney seated dimensions between both of the genders, and males have larger kidneys as well. Now, looking at our limitation of our studies, due to the retrospective nature of our study, we were unable to analyze the relationship between kidney size and variables such as height, weight, and BMI. Our study was limited to a single tertiary hospital, which does not reflect the whole Moldavian adult population. Additionally, only linear measurements of the kidneys were assessed, and therefore volumetric analysis could not be performed. In conclusion, our study estimated the average renal length in the Moldavian adults, with the left kidney being slightly larger. UST measurements showed similar renal length between males and females with no significant gender-based differences. CT findings demonstrated a larger right kidney length in males compared to females, while no significant difference was observed in the left kidney. Overall, our findings provide baseline reference values for kidney size in the Moldavian population and highlights the role of imaging in clinical assessment. Based on these findings, we propose the following recommendations using population-specific reference values in clinical assessment and diagnosis, digitalization and of radiological data records for future research, recording anthropometric data in clinical settings, standardized healthcare information system to access larger and more comprehensive data sets, and lastly, foundation for future research in nephrology in the Maldives. Thank you.
by the case. The floor is now open for questions.
We've taken patients who have undergone both ultrasound and CT, right? So we've excluded patients who have some vein conditions, probably because they may have a smaller kidney. But what are the percentage of patients that you have seen who have undergone both CT and ultrasound without a serious diagnosis, vein or vein? We can take that into consideration.
Thank you, Doctor. So in our research, we considered patients who have done both USG and CT, and we used whole abdomen USG and CT, and we actually considered that point because usually patients who had renal pathologies, they go for KUBs or the urograms mostly. However, when we considered whole abdomen scan, mostly they were done for not only renal pathologies, and most of them were done for like other pathologies too.
So one more question. Why exclude pregnant women in the CD or you mentioned?
According to literatures, it has been stated to emphasize that pregnant women undergo changes during the period, and their kidney dimensions also increase during this time period and would be different from their actual value until 6 months after they deliver. That's why we excluded any pregnant women.
Okay, one more question. If you take from the whole sample, any pregnant women who have undergone both USG and CD?
No, we did not.
Any further questions? Thank you. Up next is our last presentation for the forum, titled Knowledge, Attitude, and Practice of Self-Medication Among Students Enrolled in Universities in the Greater Mala area in January to February of 2020. Supervised by Dr. Deepesh Budapati and presented by Dr. Iman Muhammad and Shafana Ali and Riva Zahid, Muhammad Rai Ahmad, and Muhammad Zaidani.
Assalamu alaikum and good afternoon. We are Group 7 and our research is on the topic knowledge, attitude and practice of self-medication among students enrolled in universities in the Greater Mala area in January-February of 2026. These are our table of contents. Self-medication is the use of medicinal products by individuals to treat self-recognized disorders or symptoms, or the intermittent or continuous use of medicine initially prescribed by a physician for chronic or recurrent conditions. A meta-analysis of 89 studies, including 60,000 university students, reported a pooled self-medication prevalence of 70.1%. International data reveals that Eastern Europe and Asia have the highest self-medication rates globally. Regarding knowledge about self-medication, one study found that while participants had an overall good awareness, 12% lacked knowledge about side effects and only 35% knew the appropriate doses of medication. Another study found that students in natural and exact sciences and the judicial and economic sciences were found to have a higher level of knowledge. Moving on to attitude, studies found that factors such as gender, marital status, and age were found to have an impact. Regarding practice, 60% prevalence of self-medication was found in one study, with higher levels of knowledge increasing the chances of practice. So the objectives of our study are to describe the demographics of our study population, determine the level of knowledge, attitude, and practice of self-medication, identify the association between knowledge and attitude with practices, as well as between knowledge and attitude of self-medication, and identify the factors that influence knowledge, attitude, and practices of self-medication among students enrolled in universities in the Greater Malta area. Our null hypothesis is that there is no relationship between knowledge and attitude with practices of self-medication. Our alternative hypothesis is that there is a relationship between knowledge and attitude with practices of self-medication among students enrolled in universities in the Greater Malta area.
Our study is a university-based cross-sectional study, and our target population is students from these universities. 374 samples were collected, of which 41 students were excluded, which gives a final sample size of 333 students. Our inclusion criteria is students enrolled in these selected universities and students above 18 years of age. Our exclusion criteria is incomplete questionnaire students below 18 years of age and foreign students. We used a pre-designed validated structured user questionnaire and Google Forms, and we visited the universities and students were approached by convenience sampling. Descriptive statistics were used to summarize demographics and KIT scores, and we used SPSS version 22 for analysis. And these are the analytics test videos. For ethical considerations, data collection began after obtaining approval. Informed consent was obtained, and participants had the right to withdraw from the study at any time. Data was stored in password-protected documents, and only research members had access. No identifiable data was collected. Looking into our results, most participants were under 20 years of age at 42.3%. Females made up the majority at 77.2%. The majority, 79.4%, reported having no underlying medical conditions. Only 3.9% had parents working in their medical field.
When we take a look at the annual frequency of medications, a high proportion of participants, 88.3%, reported practicing self-medication, while notably 33.9% practiced self-medication more than 3 times in the past year, indicating a repeated behavior. Only about 11.7% reported not practicing self-medication. Overall, this highlights a very high prevalence in our study population. Our findings align with the high prevalence rates as reported in Uganda and Jordan, while lower rates were seen in Netherlands, Saudi Arabia, and Portugal. These differences may reflect variations in healthcare access, regulations, and public awareness. Coming to the types of medications used, antipyretics and analgesics were the most commonly used by 91.6%, followed by cold medications at 42%, while antibiotic use was relatively low at 7.8%. Similar patterns have been seen globally, with pain relievers being the most commonly used medications. However, some of the reports studies show that higher antibiotic use was there, with raising concerns about misuse and resistance. In comparison, our lower rate may reflect much better awareness and stricter regulations. As for common causes of self-medication, headache was the most common cause at 75.1%, followed by cough and cold at 73.9%, and fever at 70.6%. Other studies report similar triggers, mainly headache, fever, and respiratory symptoms. This suggests a common perception that these conditions are minor and manageable without medical consultations. The most common reasons for self-medication was perceiving the illness as not serious, which was done by 61.3%, followed by saving time 51.4%, and urgent need for medication at 36%. These findings highlight the convenience and perceived mildness as key factors consistent with other studies. Moving on to information sources, friends and relatives were the most common source with 44.7%, followed by academic knowledge at 42.3%, and internet with 41.4%. This shows a strong reliance in informal and easily accessible sources. Other studies highlight academic knowledge, especially among pharmacy students, along with pharmacists and family members as key sources. The variation reflects differences in education and access to healthcare professionals. Now, looking at knowledge, attitude, and practice scores, the most participants had a good knowledge of 67.9%, and nearly all showed a positive attitude of 99.7%. However, 87.7% demonstrated irresponsible practices, with only 4.3% practicing responsibly. This gap between knowledge, attitude, and practice is a key finding, emphasizing the need for targeted interventions.
When looking at factors that affect knowledge, attitude, and practice scores, female students demonstrated higher knowledge scores when compared to male students. However, this finding was not statistically significant. Similar findings were also reported in studies done in Portugal and Saudi Arabia. Male students had significantly higher attitude scores when compared to female students, while some studies reported similar findings, contradictory findings were also reported by other studies. Although the difference was not statistically significant, male students had a higher mean practice score than female students. This could possibly be because that females take more medications due to their menstrual and gynecological problems. We found no significant correlation between the participants' age and the mean knowledge scores. However, other similar studies have reported that older students had a higher level of knowledge. The absence of a significant difference could be due to health information being easily accessible to all age groups in our study population. We found no significant correlation between age and the attitude scores as well, while a study conducted in Saudi Arabia revealed that students aged over 25 had a higher overall attitude score. The age group of 25 years and older had a higher practice score compared to the age group 20 years and younger. The increasing age is associated with a greater practical experience and a stronger ability to apply the acquired knowledge. While students with parents in a medical profession were found to have a poorer knowledge, they demonstrated better attitude and practice scores. However, these findings were not statistically significant. This is unlike most of the studies where students with parents in a medical profession had a higher level of knowledge. Students who were in medical fields had higher knowledge scores compared to students in non-medical fields. Though this finding was not statistically significant, there was a significant difference in the attitude scores between students in medical and non-medical fields. This could be due to medical students' academic exposure, causing them to be more cautious against self-medication. Additionally, students in medical fields had higher practice scores when compared to students in non-medical fields.
Our study found a significant but weak positive correlation between knowledge and attitude. Therefore, we reject our null hypothesis. Similar findings were reported from studies in Saudi Arabia and Ecuador. However, a study in Portugal found no significant correlation. We also observed that knowledge had only a weak influence on practices. Therefore, we accept our null hypothesis. However, a study in Saudi Arabia showed that higher knowledge was associated with more appropriate practices. Additionally, there was a weak positive correlation between attitude and responsible practices in our study. Therefore, we reject our null hypothesis. Tohan found that more positive attitudes increase the frequency of self-medication, and similarly, studies in Portugal also showed that positive attitudes were linked to more responsible self-medication practices. For our strengths, our study assessed knowledge, attitude, and practices of self-medication simultaneously, which allowed for a comprehensive evaluation of self-medication behaviors. The use of a structured and standardized questionnaire allowed uniform data collection, and the inclusion of multiple universities and participants in different fields ensured a greater diversity of our sample. For our limitations, our questionnaire relied on self-reported data, so there is a possibility of having recall bias. There may also be selection bias because the sample is not a representation of the targeted population. There could also be potential underreporting on inappropriate practices due to preconceived notions about socially acceptable practices. Overall, our findings show that self-medication is not only widespread, but also shaped more by attitude than knowledge alone. This emphasizes the need for targeted educational interventions within universities that go beyond awareness, that focus on encouraging responsible attitudes and safe practices.